Well, welcome back to another edition of Nexus Connexus. Today, I am talking with Dr. Lee Surkin. Dr. Surkin is the Chief Medical Officer here at Nexus, which I think is very unique. We've talked a lot about dentistry up to this point, and we've talked to docs, but they haven't been MDs. And I think we're going to get a really unique perspective here today about the effects of sleep apnea from an actual medical doctor. Dr. Lee, thank you so much. Dr. Surkin, I guess I'll call you in this case. Thank you so much for joining me today. Maybe you could tell us a little bit about your background, because I've been reading a lot about you. You have some great credentials here, and they're stacked credentials. It's not like you have just one specialty.
Yeah, thank you, Derek. I've been at this for a while. I did my medical school training at Hahnemann University in Philadelphia, and then did internal medicine internship and residency at Yale New Haven Hospital, and then a cardiology fellowship at Yale University School of Medicine. From there, I met the woman who would be my wife and still is my wife. And she's from Toronto, and I am from the New York area, and she didn't really like the New York area. So long story short, we interviewed all over the country and ended up in Greenville, North Carolina, which is Eastern North Carolina. I joined a cardiology practice here. And, from those days on, Derek, as a cardiologist, I got this association between cardiovascular disorders and sleep disorders. The patient population across the country and in Eastern North Carolina are at risk based on weight. Sure. Issues. And, my patients have hypertension and cardiovascular disorders, and throw those into the mix, and the risk for obstructive sleep apnea really goes through the roof. Mm-hmm. So I basically started screening my patients. This is back in my days in Connecticut at Yale. Oh. I would screen my patients, send them for sleep testing, did the same thing here in Eastern North Carolina. And I would send them to my colleagues who, in those days, the sleep physicians were pulmonary doctors and neurologists and that sort of thing. And my patients got tested and they got sent back to me. And about 95+% of them had sleep apnea, and close to zero were on treatment. And so I was like, what gives here? Yeah. I'm sending these patients out. I know what sleep apnea is. I don't have the advanced training to manage the treatment, the CPAP in those days. This is in the late 90s, early 2000s. And so I called these colleagues and I said, folks, why is it that I'm sending you all these patients and they're being diagnosed and none of them are being treated? And they said, we are so inundated with these patients with obstructive sleep apnea that we simply can't manage managing the treatment. So I knew right then and there it was something that I needed to do.
So, Dr. Surkin, let's chat for a minute about what is obstructive sleep apnea from the medical definition of this.
So, apnea means without breathing, and it's during sleep. So it's airway, basically airway closure during sleep. And there's a number of different types of defined apneas. There are two that are obstructive apneas. One is where the airway is closed, where there's at least 90% or greater reduction in airflow for 10 seconds or more. And the other is where the airway is narrowed but inadequate to maintain normal breathing, which results in a drop in the oxygen saturation in the blood by 3 or 4%, with or without an arousal, a disruption in sleep. So what I tell my patients when they first come to see me, I say to them, I'm going to give you a brief sleep apnea 101 education. Okay. So I start off with telling them, when we go to sleep, we enter a light stage of sleep, a deep stage of sleep, and a dream stage of sleep. And this is simplified. Obviously, this is for the patient who I try to make it as understandable as possible. And as we go from light sleep to deep sleep to dream sleep, the muscles of our body get progressively more relaxed.
Hmm.
And when you think of muscles, you think, oh, my arms, my legs, my back, whatever. But I tell them also this involves the airway muscles. And we're going to call the airway muscles the upper airway dilator muscles.
Hmm.
So when a dilator muscle contracts, it gets bigger, it dilates. And when it relaxes, it narrows. So the upper airway dilator muscles help to support the jaw and the tongue and the neck and all these upper airway anatomical structures. So when the muscles relax as we start entering deeper stages of sleep, basically it allows the jaw and the tongue to move backwards. And as the jaw moves backwards, it brings the tongue backwards, and as the tongue moves backwards, it starts to narrow the airway. Well, guess what? This happens in everyone as we enter deeper stages of sleep, because everyone during that total body muscle relaxation, the deep sleep, the dream sleep stages of sleep, that's the rejuvenating, restore your batteries stages of sleep. So everyone has this relaxation. Everyone has a degree of narrowing, but not everyone's airway narrows to the point where it's inadequate to maintain breathing and oxygen level, and not everyone obstructs or closes off their airway. When this happens, the individual is deeply asleep and unaware of their surroundings, but the central nervous system is always responsible for maintaining breathing and maintaining oxygen so we survive the night without damaging our organs. So the brain looks back at this situation. It says, Houston, we have a problem.
Hmm.
We like the fact that we're getting this deep sleep. We need a certain minimum number of hours, typically 4 hours of deeper dream sleep to recharge our batteries. It's like plugging in your cell phone. If you don't plug your cell phone in long enough and you use it, you're going to drain the battery and eventually run on fumes. So the brain says, okay, we like this, we need this, but on the other side, we have to breathe to survive.
Hmm.
So the brain obviously chooses survival.
Yep.
And kicks into an arousal mechanism, which results in a surge of adrenaline. Hmm. Well, adrenaline is what you would experience if you're in a dark alleyway in a bad part of town and you're about ready to be mugged. Yeah. Your heart rate goes up, your blood pressure goes up. You're ready to fight or run.
Yes.
The fight or flight hormone. Okay. So as a response to you're about to be mugged, that's protective. That you need that.
Sure.
But as a result of an airway obstruction in deep sleep, that's bad.
When we talk about treating sleep apnea, is this something that everybody has happen maybe a few times a night, or is it all or nothing? Like, how does that go on the scale of, are there cases that don't even need treated, and are there cases that are so extreme that, how does that work?
It's a great question. By convention, the American Academy of Sleep Medicine, the large governing body for sleep medicine, through years and years of research, have come up with this answer to this question: how many airway closures per hour is basically safe? Well, obviously, we would like to not have any airway closures whatsoever. And so the answer is that less than 5 airway closures per hour doesn't seem to result, in general, in daytime symptoms or in long-term negative health consequences.
But I always wondered this: is one the cause of the other, right? In that sense, it's like, do you have obstructive sleep apnea and that results in cardio issues? Or is there no conclusive evidence yet that shows that?
Well, the interesting thing about obstructive sleep apnea and cardiovascular disorders is that when you look at the risk factors, they're virtually identical. Huh. The weight as a risk factor, high blood pressure, stroke, they just cluster together. So it's tough. It's difficult to be definitive from a causality standpoint. We know that The heavier an individual is, the larger their neck gets. That neck size compresses down the airway and makes it more likely to obstruct during, the deeper stages of sleep. So that's where obesity comes into play. High blood pressure, for example, we know that that obstructive sleep apnea is a cause of hypertension. And we know that treating obstructive sleep apnea can help improve hypertension. That cardiovascular patient population, for me, from my perspective, right up my alley from, a sleep apnea screening, testing, and treatment perspective. In all of the countless numbers of patients that I have screened, tested, and treated over the years, within my practice, the patients who get screened, tested, and treated for sleep apnea seem to do better.
Well, it sounds like it is a chicken and egg, right? I mean, who knows which one really comes first, but there does seem to be a really strong correlation between those things. So what are the telltale signs? If I'm listening to this podcast right now and I'm saying to myself, I wonder if they're talking about me. There's probably been some little tinge so far in this where you're like, ooh, I sort of feel that might be me. I mean, what are the things that you as the patient should be, if you hear these things either in yourself or in your spouse or in your child, what is the time to go seek action? And what are those things that should trigger that?
Yeah, great question. I would say that individuals with any number of the following complaints should, seek to at least be screened and considered to be tested. So if individuals are awakening feeling unrefreshed, I wake up and I feel like I need more sleep. I'm still tired after getting adequate sleep, which is typically 7 to 8 hours. Sleepiness during the day, fogginess, just not thinking clearly, not feeling sharp, awakening with a headache, awakening with a dry mouth, awakening during sleep, as you mentioned earlier, choking or gasping. A bed partner or someone who sees you and says, I saw you last night and I don't think you were breathing at times. That's pretty convincing stuff, where it's witnessed. Waking up frequently at night. This is another one that's not really well known or well spoken of. There's complex biochemical changes that occur as a result of apnea events that actually can result in a greater degree of urine production. And then when you obstruct the airway, there's a cascade of muscular contractions as your brain is arousing you and trying to get you to breathe, where your chest is contracting, your abdomen is contracting, and you're like, until you open your air. Well, so when your abdomen contracts, it puts downward pressure on the bladder. And then there's a feedback loop to your brain. That's your bladder. My bladder is full and you're making more urine. There's actually stretch in the heart that results in the production of a substance that causes more urine production. And so you have to wake up to go to the bathroom more often. Now, in a middle age or older male, there's prostate issues that
trust me, when you go camping with a bunch of guys, it used to be you'd sleep through the night, and now it's like every time you go out, there's 3 other guys out there.
So I saw a patient earlier today that before their treatment, they were waking up 7 to 8 times a night to go to the bathroom.
Wow.
And they're on treatment now. They're actually on a dental appliance now, and they're not waking up at all to go to the bathroom.
That's amazing.
It is really amazing.
I knew that guys like me were affected by sleep apnea because I've had a CPAP years ago, and I lost 50, 60 pounds after I started using the CPAP. So I'm like, I get the connection. I was shocked to see how many women, how many even athletes or children that had been affected by sleep apnea as well, that don't fall into that statistical average of, well, we know it's, there's these causes and that correlates with sleep apnea. Maybe you could talk a little bit about that, because I think obviously there are risk factors that will affect if you're subject to sleep apnea. But surprisingly, it seems like more and more people are being diagnosed that don't fall into those averages.
Yeah. Starting with children, obviously boys and girls, there's just a very a growing prevalence of attention deficit hyperactivity disorder, attention deficit disorder, concentration disorders in children. And I know that others on this podcast will speak to this, that somewhere around 50-60% of these disorders can be ascribed to sleep disordered breathing or obstructive sleep apnea. So, for example, boys and girls who snore, that is not normal. That is not normal. So boys and girls who snore, boys and girls who are mouth breathers, very abnormal to breathe through your mouths. Our creator created noses to breathe.
Yeah.
Okay? Mouths not to breathe.
It's one I used to do a lot of backpacking, and that's one of the first things you learn is you have to be very careful with your breathing when you're climbing mountains, because it's really easy to wind. You can wind yourself and get into a position where you have a really hard time breathing. Yeah. So you do have to learn how to breathe properly. Absolutely. And does that seem to be what do you believe the causes of that are? Is it part? I know I've talked a little bit with some dentists, and they've talked about how, our jaws are getting thinner because we're not chewing, grains anymore and crunching nuts and doing the things that, for tens of thousands of years we did. Does that seem to be, there seem to be some correlation?
You're spot on with that, Derek. It seems to be the evolutionary anatomic physiological changes that result in narrower airways and narrower nasal passage, leading to more prominent adenoids, relatively speaking, more prominent tonsils, relatively speaking. And it really starts at the nose. Yes, removing the tonsils and adenoids are typically, the first thing that is thought of amongst sleep physicians in collaboration with our ear, nose, and throat partners. But it really starts at the nose. So we mustn't just remove tonsils and adenoids in these children without ensuring that their nasal breathing is normal, is adequate.
That's great. Let's talk a little bit about dentists in particular. Are you seeing many dentists? Are they practicing in these snore guards right now? Or is that they're just sort of staying away from that whole practice in general?
My sense is that dentists are moving away from, the undiagnosed, let's just give you an appliance, undiagnosed sleep apnea patient, just give you an appliance, hey, this will fix you, to a more appropriate clinical pathway towards a proper official diagnosis, towards collaboration with the medical doctor, with the board certified sleep physician, as I said.
I'm so glad you're on the team, because it really does make a difference. It's one thing to say, hey, here's a snore guard that'll help you if you snore. But it's another thing for somebody to say, I have sleep apnea. Can you come up with it? Like if it's, they're treating a medical disorder. That's not what dentists do, right? I mean, I can get it if it's you're grinding your teeth. Well, of course you want to have some device that goes along with that. But I think that's the greatest part about what I have seen, and even in dentists that are friends of mine, and I've started to tell them about Nexus, and it's like, look, the first two things that they bring up if they really care about, their patients is, all right, well, who's the doctor, right? Who's the actual, and that's not saying, they're not knocking dentists. They're just saying, who's the medical, doctor that's here, that's overseeing this process. And how do they do the sleep study, and where are the devices created, and how do I deal with medical insurance? So, I mean, there is a little bit of that communication breakdown, I think, that happens between the two practices. And I think that's what's so great about Nexus, is trying to bring those practices together and say, together we're much better than separate.
That's what Nexus is all about, is creating that pathway for individuals to easily get tested through collaboration between the board certified sleep physician and the qualified dentist, to get more individuals screened, tested, and treated in the most appropriate way for that individual. We're forging relationships between dentists and sleep physicians nationwide. We're providing a pathway for dentists who want who want and need the education on sleep medicine to become qualified dentists, and then ultimately diplomats in dental sleep medicine through the Academy of Clinical Sleep Disorders, part of Nexus.
So for dentists that are watching this, what would you say to them about, right now, there's probably a lot that are sitting on the sidelines that are like, I'm not really sure, if I bring this into my practice, how much extra work is it for me? Is it worth it? Are there things I can see? I mean, is this an easy conversation to have? Maybe if you could just, talk for a minute about you're playing golf with a couple dentists. What would you say to them when it comes down to?
So first of all, it's well known that people in general tend to see their dentist more than their primary care provider. And the American Dental Association has advised dentists that it's appropriate to screen for obstructive sleep apnea a number of years ago. We want to elevate the dentist to sit at a seat at the table with the other major healthcare providers in the United States. We believe, as do I, that is a missing link in our struggling healthcare system in the United States. Yeah. If dentists can and are willing to step up to the plate, elevate themselves to the level of a team caregiver with primary care, with subspecialists, etc., then they will have a tremendous amount to contribute. It takes time, it takes dedication, it takes collaboration, it takes an interdisciplinary approach, a team approach. The role of oral appliance therapy is untapped. I'll say it's untapped at this point. Yeah. It's an untapped resource. It is a first-line treatment for mild or moderate obstructive sleep apnea and an alternative treatment for severe at this point, along with CPAP. And so, those are the first-line treatments. And that collaboration is there for the dentist that comes through the Nexus pathway and does it the right way. And he or she can rest assured that it will be done the right way. It is being done the right way, and the patient's care and outcomes is in first place.
If you think about it, if you're a dentist, you want to improve the healthcare outcomes for your patients, and some of that is, hey, if they don't have a cardiac arrest at 70 years old, that's a pretty good outcome, right? From you, but you are the frontline defenders here in this, because you're right. I will admit, I go see my dentist every 3 months. I like to have my teeth clean. I like to get them checked. I do not want anybody drilling. So I go very, very frequently, and they are a frontline in the healthcare game. And I think it's important too to understand the role everybody plays. Thank you, Dr. Surkin. This was really great, but I think there was so much great, fascinating stuff in there we'll really be able to use. And I think, just your background and expertise is going to make dentists feel very comfortable with Nexus. So thank you so much for your time. Thanks again, Dr. Surkin. I think that was such important information for both patients and dentists. If you're a person who's suffering with any of the classic signs of sleep apnea, or your partner says you are, you should be tested. And if you're a dentist, reach out and find out how you can incorporate Nexus dental systems into your practice. It's both good for you and good for your patients. Next time on Nexus Connexus, we'll continue to explore the world of sleep apnea and how it affects us and our families.
In the human race, and we won't stop dreaming.